Thank you again for the invitation, and it's a great honor for me to be with you. My topic today is subscapularis tear, hidden lesion even in arthroscopic field. So when we suspect a subscap tear, there are many symptoms and signs related with the subscapularis tendon tear, such as anterior shoulder pain or the belly press. So I think of importance one is the weakness in rotation compared to the contralateral side. On radiology evaluation, sometimes it is difficult to identify the subscapularis tear even in MRI. In many cases, it appears to be normal. This gentleman is 64 years old who underwent arthroscopic repair for the anterosuperior rotator cuff tear. This patient has an internal rotation weakness on preoperative physical examination. Take a look at the axial images. The subscap insertion looks normal. From the posterior viewing portal for this patient, it looks a tear of this area, subscap insertion, although I'm not sure whether this tear requires repair or not. This is a normal tendinous portion of the subscap, and you see there's something wrong at the subscap insertion. So take a look at this area. So I think it seems to be full skinless tear. You see there is an exposed footprint, although it is hidden by the superior glenohumeral ligament. So I take down the superior glenohumeral ligament. It's not a subscap tendon, just the superior glenohumeral ligament, and then you will see the bare footprint of the subscapular tendon like this. This is another case. In the right picture, there's no retraction, and subscap tendon looks fine through the 30° of the arthroscopic from the posterior viewing portal. But this patient has an internal rotation weakness on preoperative physical examination. Using the 70° scope, I confirmed the full skinless tear without any retraction. So I took down the superior glenohumeral ligament, and we can expose the bare area of the subscap footprint. These are all subscapular full skinless tear. In advanced case, we can identify this kind of the retraction. But in many early stages of full skinless tear, there is no retraction. Because I think despite the full skinless tear, the subscap tendon was tethered by the transverse ligament of the bicipital group. We investigate the neglected subscap tendon tear at index surgery in revision cases. 43% in revision cases, the neglected subscap tendon, subscap tear was identified. I think all these were hidden by the superior glenohumeral ligament at index arthroscopic surgery. Thus, we define the hidden lesion, the subscap tear requiring repair, not visible with the 30° scope, but visible only with the 70° scope from the standard posterior portal. We wonder and investigated the prevalence of this hidden lesion in subscapularis tendon tear requiring repair. It was 90% of our cases. Also, we compared the hidden lesion with non-hidden lesion. This hidden lesion shows significantly low detection rate at preoperative MRI and earlier stage of the subscap tear. So I'd like to introduce the subscap repair in subaqueous space, so-called out-of-box approach. I think there are many steps in subscap repair, but I think the most important one in we address the subscap tear is swelling management and good visualization. So first, usually I open the rotating interval using the shaver like this. Usually, I prefer the beach chair position. So I open the rotating interval using the shaver like this. And then, once the rotative interval was open, the swelling get worse. So usually the fluid let the run down. So like this, some surgeons prefer the outflow or something, but I prefer the fluid let the fluid run down like this. So switching to the 70-degree scope for better visualization, I prepare the bursal side, the bursal of the subscapular bursal side like this. And then from the anterior portal, using the cannula like this, we can fold down the subscap and we can expose this subscap footprint like this. And then using the electrocautery and acumenizer, we can prepare the footprint like this. And move to the subacromial space using the 70-degree scope. And you see when we approach the lateral portal, if we use the 30-degree scope, footprint exposed like this, but if we use the 70-degree scope, this view I think is much more familiar. Also, as I told you, the good visualization is important, and swelling management is also important. But when during the subscap repair from the lateral viewing portal, sometimes the deltoid got swollen, so it usually hindered the good visualization. So using the switching stick, we can lift up the anterior deltoid portion and we can obtain better visualization. So this is the lateral viewing portal using the 70-degree scope. And in many cases, as I told you, despite the full skin tear, the subscap was, there is no retraction like this because the subscap was tethered by the transverse ligament of the bicipital group. So we need to release the transverse ligament like this using the electrocautery, and then we can expose the subscap footprint like this using the cannula from anterior portal. And I think it's much familiar. And then for this case, I used the 2 anchor for repair, and using the after ankle insertion and using the suture passer, the suture was passed like this. And for the subscap, I performed the repair in a single fashion. And for this patient, the anterosuperior tear was repaired like this. So this is my take-home message. Do not miss the subscap tear, full skin subscap tear hidden by the superior glenohumeral ligament. In addition to the preoperative physical examination and MR finding, carefully arthroscopic examination is using the 70-degree scope is critical. If the subscap tear is suspected, take down the superior glenohumeral ligament. Thank you for your attention.